सब वहाँ पर जाके क्या करना है. So we thought that we should start our CME with this discussion on what a nephrologist should do in dialysis unit daily. And this is a panel discussion, and we have 4 distinguished faculty with us: Dr. Tarun Jeloka, Dr. Hegde from Nadiad, Dr. Umesh Khanna from Mumbai, and Dr. Ookalkar from Nagpur. So we directly go to the main subject, that a nephrologist has to manage patients, he has to manage machines, monitors, and all the equipments in the unit, as well as the personnel, the staff, nurses, and other paramedical staff. And also has to manage documents and records. So there is a lot of work that a nephrologist needs to do in his own center, as well as centers which are owned by hospitals but managed by him. So this is a list of what I am going to see in a patient, but there may be lots of things apart from patients, and we'll come to those. First of all, I would like to talk to the patient, know his status currently, and what problems he is facing, because dialysis cannot really cure or cannot bring life to normalcy. So what problems he is facing, and can we address those problems? Then what is his BP currently? What is his weight gain compared to his dry weight? What access he is using, and can I shift to a more permanent access? And assess the dialysis quality that he is receiving. Modify his dialysis prescription accordingly. Review his medical prescription, and also pay attention to his nutrition. So what I'm going to do over next about 1 hour is I'm going to pose questions to all the faculties, and they're going to share their views on those particular aspects. So first is for Dr. Jeloka. So how do we assess dry weight, and are there any tools for those?
Okay, so this is one important thing which we manage when we take rounds in dialysis unit. So dry weight, what is dry weight? Actually, dry weight is edema-free post-dialysis weight with no or minimal blood pressure medicine requirement, and without any lightheadedness or fatigue post-dialysis. So this is basically the definition of dry weight. And how do you assess it? It's mostly clinical. So you look for edema, you look for JVP, you look for blood pressure. As I said, the blood pressure should be normal. Ideally, it should be normal. It may not be always true. They may require blood pressure medicines. So clinical evaluation by virtue of edema, JVP, and blood pressure will give you a sense that this patient is overweight or above his or her dry weight, and you start adjusting or coating the dry weight so as to manage patients on dialysis. There are other ways, objective ways of assessment of dry weight also, which may assist, which may not be routine. But routinely when we go to the dialysis unit, we look for edema. It's difficult to assess the JVP because the patient is lying flat, but blood pressure and edema can give some idea about the dry weight.
Yes. So how do we achieve dry weight of a patient?
Okay, so this is something practical. So when you see edema, that means definitely the patient is above his or her dry weight. So you start reducing the targeted dry weight. So somebody who has, for example, a weight of 50 kgs right now, and you see edema, possibly there are 3, 4, 5 kgs extra water in his or her body. So you will start decreasing or setting up the ultrafiltration accordingly. So you cannot put 5 liters of ultrafiltration at one go because patient may not tolerate it. So graduated planning should be there if a patient is new, and slowly you keep decreasing the dry weight. It is possible that the patient may not tolerate because of multiple reasons. For example, cardiovascular condition of the patient, especially in elderly patients, those who have heart disease. And some patients, because of hypoalbuminemia or poor nutritional status, also do not tolerate significant ultrafiltration in one go. In that case, you have to graduate the ultrafiltration in subsequent 3 or 4 sessions and keep readjusting the dry weight. So this is clinical way of achieving the dry weight. At the same time, keep monitoring the blood pressure, ask questions about post-dialysis feeling of the patient, whether they are lightheaded or they are crampy. If they get cramps, then obviously you have to go much slower than that. Sometimes you can tweak in the dialysis machine also. If the ultrafiltration is not possible, desired ultrafiltration is not possible, you do a sodium profile. You ask them to restrain salt and water in between dialysis sessions so that they do not have a weight gain in next subsequent dialysis. And then BIA can also be used as a marker, as a tool, which can give you an added objective way of assessment of dry weight. So these are some practical ways by how we achieve the dry weight.
And is there any maximum ultrafiltration rate? And how do we manage antihypertensives? Because most of these patients will have some or the other.
Right, so maximum ultrafiltration rate. So if you go by evidence, the literature says that anything above 10 mils per kg per hour has higher chances of complications during dialysis. But it's very difficult to go just by this guideline because, say for example, 50 kg person, as I said, so 500 per hour, that means only 2 liters you can remove. And when you go to dialysis unit, invariably you will see patients having an ultrafiltration of 2.5 liters, 3 liters, going up to 4-5 liters as well. So it depends upon tolerability of patients as well. So some patients can tolerate very well, some patients can get cramps even with small amount of ultrafiltration. So yes, beyond 10 mils per kg per hour, the complication rates as of evidence and literature is higher. So that is the maximum I would permit, but then you have to individualize depending upon the requirement of the patient's need.
Thank you, sir.
And so blood pressure, the other question part was antihypertensive medication. So see, once the patient is on long, say for 3 months on dialysis, they are usually stable. And they may require change in blood pressure medicines or dry weight once in a while. But the problem is with a new patient who has come with significant amount of swelling. So proteinuric patients who had lots of swelling now went into ESRD and dialysis has been started. So these are patients which are difficult to manage initially, where they will require frequent change in blood pressure medicines. So number one, they have to monitor blood pressure frequently even at home. Pre and post dialysis blood pressure will be important. And apart from fixed dose, for example, if I tell them to take amlodipine twice a day, or maybe ACE or ARB along with that, or maybe alpha blockers, I always tell them to measure blood pressure at home and give one or the other medicine to be taken if the blood pressure is, for example, more than 140 or 90. Or hold the blood pressure medicine, this medicine to be held back if the blood pressure drops below 120/80. So these are all trial and error method by which you finally reach to a position where patient achieves dry weight or near dry weight, and then that is the blood pressure medicine, either no blood pressure medicine or 1 or 2 blood pressure medicine, by which blood pressure can be maintained.
Thank you, sir.
So any other comments or some, I mean, feel free to,
I think
it's an informal thing, so anyone can jump in and modify their practice. And
I would like to add two things. One is removing the fluid from the body and seeing that the patient doesn't consume too much of fluid. And therefore, what I do is to give them water bottles with markers. There is a plastic marker here, 100 ml marker. And the bottle gets over, the marking gets over at 800 ml. So they can at one go only fill 800 ml of water. So about 1000 to 1200 ml of water if they can consume, rest 400 ml in the night, 800 during the day. It helps in reducing the interdialysis weight gain and facilitates. Second thing is I ask them to prepare salt-free diet. Breakfast, lunch and dinner. पहले पेशेंट का बनाओ, निकालो बाजू में, फिर बाकी फैमिली मेंबर्स के लिए नमक डालो. For him, I give a 5 gram salt packet. Everybody gets a 5 gram salt packet, and that's the only thing which they are supposed to use. And then the dietitian counsels that if you, to reduce the craving for salt, you can squeeze a little lemon, and that will reduce the craving for salt. So both the things need to be done: remove the fluid as well as reduce the fluid intake.
I agree, but in some of the patients who are coming twice a week, it is very difficult. They start getting hypotension at the 4th hour or 5th hour. And if you put more ultrafiltration rate, which is hazardous, especially elderly people who have hypotension and collapse after that. Yes. So these patients, what we started doing only 5 hours because they can't come for third time. So do it for 5.5 hours if their time permits. Most of the people agree. So reducing the ultrafiltration rate and extending the duration, we are able to achieve the dry weight in such patients.
And
I
see
think
that
what
the
they are
technician-
saying.
See that the technician has set the dialysate sodium correctly. It's nearer 135 rather than near 140.
I think all these points you are familiar with. So what he mentions, theoretically it's easy to understand. In practice, when you meet those patients, it is difficult. But I think again the take-home points are the same: salt, water, interdialysis weight gain to minimize. These are the disciplinary things which the patient has to understand. Those who are disciplined will be able to manage their dialysis well. Others will have difficulty. Those who are diabetics, those who are hypoproteinemics, those who are anemic, those who are elderly, those who have a bad autonomic neuropathies, these are the patients who are going to trouble you, whatever theory we teach you. But I think salt, water, interdialysis weight gain is the clue to it.
So next set of questions is for Dr. Hegde, and again it can be other input can be added. That how to quickly examine AVF when a patient is coming for dialysis, and how to monitor the AV excesses, how to predict their dysfunction, and is there any role for venous pressure, because seems to be some confusion in the student's mind, and is there any way to monitor TCCs?
So basically, quickly is first we'll have to see, observe, then palpate, auscultate. So then it will be better. But basically, when you see whether veins are visible, what is the segment which is available, it is not inflamed, and there is no aneurysm. And in between the two, whether the veins are visible or completely collapsed, or there is a stenosis. And even the chest wall is, sometimes the collaterals are available. If there is any central vein stenosis, then you will be able to have. And some of the patients, then they may have effusion also. So when palpate, whether the thrill is good, it is continuous, or in between whether there is any stenosis is there, you can palpate. So if it is compressible, it is good. If it is with flow, if it is pulsatile or it is tense, then some of the brachial fistulas will be tense, but there is no obstruction. So we should not take it into think that it is tough, but it may be a high flow fistula. So that is the reason it may be seen that it is. So you may not have a central vein stenosis. And the aneurysm, whether it is good, you may be picking the every time in the same place, so there may be an aneurysm development. So better to change the position as such. Otherwise, and there is an inflammation, its warmth is there significant in a local area, then we need to see that's possibly it is infected. We need to change the site, otherwise it may burst at that site. And auscultation is basically whether the bruit is continuous or intermittent. Only systolic is not a good thing to have. It should have a systole or diastolic bruit, continuous BB, and whether it's in a central vein significantly high flow, or there may be some patients with an increased flow, they may have a effusion. So auscultation on that side, whether the breath sounds are good or not, we need to see. Quickly, you observe it and then compress it. If it is compressibly, it is good. The inflow is good. So you raise the hand, it is collapsing completely, then the outflow is good. So minimum this has to be done. But again, the inflow extent or the central vein stenosis by raising, it's a good test, except for a very high flow fistulas. Otherwise, inflow, sometimes it is difficult to manage. You may have augmentation positive, but still the flow may be poorer, especially in an arterial disease.
So is there any role for venous pressure monitoring in
Yes, absolutely. It depends on venous pressure. It's every patient it will be difficult. In a radiocephalic fistulas it will be good. Even 300 should be less than 150. So if it is more than 300, then it may come up to 200. But especially in a brachial, it will be higher in high flow fistula. So every time you need to monitor serially increasing venous pressure after 1 or 2 hours or 3 hours. If it is more than 200 to 250, then and serially each month it is going up, then it is a clue that you are probably having an obstruction in the central vein. You need to first do a Doppler or a contrast, or you can do a CT also if it is problematic. Then you can have to see and you need to solve the problem. And if it is that, it has to be tackled early, otherwise it may close anytime if there is any minor hypotension. So either only plasty is better, but putting a stent is only a last option. With most of these people will have it is tough. Veins are tough to dilate. So, but repeatedly they may require things. But again, it costs. Now with Ayushman, where you can get it done at a free of cost with good things. So you'll be able to handle it. Venous pressure monitoring for each patient and serially looking at it is an important thing. And also the patient, if he has a bleeding should stop after half an hour of compression. If it's long duration of bleeding, then it is definitely inviting trouble. So we need to take care of it.
Yes. So off the record, so is it, what is your take on fistula belts?
Fistula?
Belts. So should we apply
Belts' pressure will be very, very high. Actually, it only required around 30 to 40 minutes. So if you can have a tight, any sticking plaster will do. Fistula belt is not compulsory, but if there is any brachial fistula, sometimes the pressure requirement is high. Such patients will definitely benefit because pressure applied to that much of time, it will be very, very difficult. So about monitoring of a TCC, again, you need to see for is there any inflammation in the exit site, whether the suture is there, it is there or not. So because even after a long time, for 1 year, we have seen the cuff is extruding. So cuff, whether it's in place, it is not seen. And even there is an inflammation in the tunnel, which needs to be seen. And whether the flow is good or not, even in the position, change in the position, if the cuff or if there is no flow in one of the things, then we need to evaluate. So if there is only arterial and you're not getting venous and you're getting, you may have to reverse it, but there may be a lot of recirculation which may happen. Or if it is long duration, there may be possibly a fibrin sheath or a clot at the tip of it which is acting as a closed valve. So these are the patients we need to monitor it. And some of the patients we saw even the cuff after 1 year it is coming out. So then we need to change it over a guide wire. So it is very, very, and even the crack, if there is any, when you are using it, and if there is any bubble you are seeing, possibly there is a crack which is not seen routinely, and because of the high flow, you are getting cracks. So air bubble is also an important thing we need to know.
Yes.
So what about arterial pressure monitoring? What is
Yes. Sir, I think that we'll cover that in the workstations tomorrow. Yes. Yes.
Belts are generally put because a fistula is bleeding for a prolonged period of time. Now that, as Dr. Hegde just said, is a sign that there is a stenosis.
Yes.
Now once the belt is put, the staff in the unit are comfortable, they can send the patient home. They will forget to report that this patient has prolonged bleeding. The patient is scared of it bleeding at home, so he will not remove the belt after 1 hour. He will keep it off for 6 hours to be on the safe side. And the first thing you know is when the fistula thrombosis. And the second point about TCCs that he made, the sign of a fibrin sheath is that there is no flow when you apply a syringe and try to aspirate, but you can push in saline easily. So there is a ball valve effect. That is a clear-cut sign that the lumen is patent, but there is a fibrin sheath external to the catheter.
So what we do in our unit is we don't apply belts. We put pressure. We give pressure for about 10 to 20 minutes, depending on the patient. And once the bleeding is stopped, we just put the dressing and discharge the patient. So belt is used only for one patient who has very high flow fistula, and it takes because she has stenosis and we cannot really repair it.
So especially the proximal fistula,
Yes,
which are very, very powerful, you may.
Yes. So for Dr. Khanna, I have a query that I get a call from the unit telling that a patient has got chills while on dialysis. So what should I do? What should be the immediate management? What can be the causes? And how do I find the cause? And how do I tackle the cause?
Since I'm getting old, I thought I'll make some slides so that I don't forget certain points. So first thing you have to remember is every case of RIGORS in a dialysis unit is not always related to vascular access, but then the antenna should be high. The first thing that should come to your mind is a vascular access because it can lead to repercussions which could be dangerous. Simple things first. I mean, in winter and in the powerful AC of the HD unit, even when I go, especially if you have a weak kind of, into inverted commas, dialysis patients, he can feel cold. But that's cold, not really RIGORS. So one needs to differentiate between the two. Yet again, on the terrace of a wintry morning, and we are in Maharashtra, so it's not that bad, but in the northern India, the RO plant and the pipe, these also shiver. So transmitting the chills onto the malnourished dialysis patients. So they are just simple things I thought before we go on to the scientific major issues. So next, please. Now, when you have fever in a dialysis unit, Obviously, the first thing that comes to mind is vascular access related, and as we all know about the catheter, even in a fistula, which is very chronic, long-standing, slight aneurysmal dilatation is there under the skin, there could be bacteria, and the moment you start dialysis within an hour or half an hour, you could have chills related to the organisms which are in the fistula skin subcutaneous tissue. So you always know about the perm cath and the temporary catheter, but also to be kept in mind is the occasional fistula patients. Of course, you have dialysis unit as the major cause of fever in those who are having a fistula-based dialysis and not a catheter-based. And there are many reasons to it. But don't forget that the patient also has a possibility of developing medical illnesses like a urinary tract infection, especially those who have polycystic kidney disease or children who have Charcot, obstructive uropathy, etc., stone patients. These are more likely to develop UTI. Respiratory infections are very common. We all know about it. And in these patients who are eating slightly outside food rather than home food, they could have a GI infection. Of course, many of them, you are aware that CKD is also makes them prone to pancreatitis, gallbladder infection, and so on. And of course, any dialysis patient has a right to develop TB, and in today's world, COVID. So all these are causes of fever which you have to keep in mind. Next, please. But the sources of infection in a dialysis unit should be aware, you should be aware of it. Next, please. Of these, we are not talking of vascular access now, the non-vascular access based. And of course, we are going to have tomorrow morning, I think, a full-fledged session by Dr. Ignatius. So we'll just run through it. Don't go into the details. But we know that the RO water, the tank water stagnation, next, please, the loop lines, the water distribution system, and don't forget the bicarbonate dialysate preparation and storage, which if it's not done properly following protocols, that could be another area where infection could be. Next. The dialyzer reuse we are all familiar with, that how not a proper handling of the reuse format can lead to fever and chills. The machine, I think the area where many of these centers where there isn't much supervision, it's the transducer protector and the issues related to that. And of course, machine disinfection issues when you don't follow. Now, how do you take what is the source of fever? I mean, vascular access is easy unless proven otherwise. Somebody with a catheter, the infection source, you must have that as the first priority. Fever only in the dialysis unit and not at home is obviously dialysis related most often. You could have sometimes variation. More than one person having it in a shift is unlikely to be the access related. There is something more to it, why more than one person is having it. In some centers, especially some of the charitable centers in the early morning shifts, the technician hasn't made fresh bicarbonate, he's using the night one, lazy or whatever you call it. Some patients, they had gone out of Mumbai or, where I practice, but have come after 7 to 10 days. Remember when you use, say, Renaclin or Imoclin or whatever for reuse, the effectiveness doesn't last more than 5 to 6 days. Maximum, I think you could use it for 7 days, but it's always risky. So it's best to use 24 to 48 hours ahead. You reprocess your dialyzer tubing and then use it. So those who have come after a gap to your unit, and if the technician has used the same old dialyzer tubing, remember, that could be a problem. And of course, you have center is not doing, you have an ICU machine in some of the single nursing home places. This is not so for corporate and teaching hospitals, but people have only one machine, and there the patient is used after 8-10 days, or the machine is used infrequently. Then again, the entire piping system, the RO system and all that could be responsible. We all know that you should not use tap water in the washroom area, but occasionally I think in the reuse, if the line is defective or whatever, if patients, the technician has used. This all I think will be covered by the other. Yes, remember, high flux dialyzers are used in places where the water treatment is suspect, is bound to lead to more fever and rigors due to the back filtration issue. So you need to be careful in centers which do not have a up-to-date system. And occasionally, and that was important during the, ultrafiltration or the intradialysis weight gain, in people who have low blood pressure and you need to dialyze and remove 3 to 4 kgs, we tend to tell the technicians keep the temperature slightly on the lower side so that feeling a little cold, the BP doesn't crash and you are able to remove more fluid. So temperature settings sometimes are altered by the technician for different reasons, and you could have RIGORS. But again, the last line, if catheter dialysis on the source of fever is vascular access unless proven otherwise. Thank you.
So I think my contribution is we need to have a reminder system in the dialysis unit's management so that if somebody's dialysis is due, a fellow is coming after 7 to 10 days. On day 7, there has to be a reminder that this fellow's disinfectant needs to be changed. And I find Google Calendar to be very useful in implementing such recurring tasks which sometimes are irregular.
Good point.
Dr. Hegde.
Well said, sir. Only one thing, as you said, the winter, even the summer may be problem because the machine has a heating but not the cooling. So even very high degrees like 43, 44, then we may have problems. Everybody, you said, it is not the patient's problem, it is the unit problem. So the heating water may be very hot. So it is not cooled completely. You may get a fever at the end of dialysis. It may last for around 2 to 3 hours.
The technician can set is 35 to 39. So if your water is more than 39, the machine is going to go in
Bypass mode.
However, 39 is 102.5 degrees Fahrenheit. So that's pretty high. So
What about chilliness?
chilliness 35.
35.
So that's about 96.
So only 2 or 3 hours after the dialysis they may be.
Borderline. If it
Yeah.
suddenly dips below 34.9, the machine will go in bypass. So usually people don't set 35. They would set 35.5 and above.
Correct.
Can I simplify, sir?
Tarun.
Yes, sir.
So just for simplification of what Sir has said, Sir has told everything. If a patient, I go to dialysis unit and see having chills and I find that my plant is working okay, then it has to be infection. I mean, there will be other reasons also, lower down inflammation, arthritis, this, that. So those are rare events, but it has to be infection unless proven otherwise. And you have to evaluate for infection, whether it is a line infection, access infection, pneumonia. And I'll tell you, 3 patients in last 1 year ultimately went up to PET CT, and there were retroperitoneal and all these lymph nodes which came out as tuberculosis, what he said. So you have to go up to an extent of PET CT also. So infection has to be ruled out once chills are there.
I think this will be covered
Yes, sir.
by Dr. Ignatius, most
Yes,
of the
sir.
things.
So you
Yeah, all
want to make
these
some,
No, I think that's...
okay. So then we come to reuse, a much debated topic. So how do we do it, manually or automated? How to make sure that the proper disinfection is done by the technician, and when to discard the set?
Okay. So dialyzer and tubing. So we have given up tubing reuse, but you can do it if the cost is the only constraint. So many centers have given up reuse of tubing. They are using it once only. But that also can be reused, only the reason being cost factor. Dialyzer reuse, again, you can use a single use dialyzer or reuse. Most of the centers in India, I think, are reusing it. Most of the centers, again, for the cost effectiveness. There might be other benefits as well, theoretical and sometimes proven also. So how do you do it? We do it long back, right from the beginning, automated, but again, you can do it manually as well. If the facility is available, the machine is available, we do it automated. Otherwise, you can do it manually as well. So do you want me to tell how to do it, or?
No, sir.
Okay.
I think
so
that is
automated
covered in
is
guidelines.
preferred. See, the difference between automated and manual is automated is more predictable. Manual is more cumbersome. In automated, you get more information. For example, you will get idea about the fiber bundle volume. You will get about the idea of pressure leak testing, all these things, which you have, if you have to do manually, then it is going to take lots of time. And in a busy unit, for example, there are like more than 10, 12, 20, 30 machines. The piling up of dialyzers, and you'll require 2 or 3 manpower just to do the reuse processing of the dialyzers, which is again not very feasible, not easy. So I think automated is preferred, manual can be done. Simple answer to that.
Yeah. So how to make sure that it is proper
disinfection process is done. So This is very important, though I don't think that we are checking it routinely. Many centers might be checking, I'm not sure. We started using it initially with every session, but then we started doing it randomly, and then actually we have given up unless there is a suspicion, to be honest. In my center I'm talking about. Yes. So it can be checked. Visually you can see, if you hold the dialyzer, whether the disinfectant is, you can see the brim of the disinfectant and all this. But ideally speaking, you should check it with commercially available strips or reagents which are available. So if you are using two of the formalin, people have given up, so most of the centers are using peracetic base. So commercially available strips are available, hemochecks are available. So before priming, if you put a drop of the dialysate compartment fluid into the strip, if it turns dark brown or black, that means it is strongly still disinfectant is present, right? More than 2000 milligram per liter. So whatever commercial brand you are using, so you, before priming, you drop in few drops on the strip. If it turns dark brown or black, then probably the disinfectant was present. So you are sure that disinfection was done, properly done.
How do I know that when to discard the set?
So again, initially you have to look at the dialyzer. Some are aesthetically looking bad. Some have fibers which are discolored, turned black or dark colored. And roughly, if it is, the recommendation is, if it is more than 20% discolored fibers, rough estimation, you can discard. Others are, if the fiber bundle volume is below 80%, then effectiveness is less, then you can discard. Then if there is pressure testing and there is leak, obviously you have to discard. There are clots which are unremovable, so you can open up the rings and then the cap and rings and you can wash it, but sometimes it's difficult. There's a large clot which cannot be removed, then also you can discard. Then there are other parameters. For example, there is multiple use and you can see that URR is below 65%. Then probably the dialyzer has lost its effectiveness. So these are certain reasons why people have to discard. And then in our unit, we used to follow that cutoff is 12. So even if the dialyzer is good, more than 80%, we never went for 13th use of the dialyzer. So that kind of protocol also can be followed so as to keep a check and balance.
Yeah. I did a cost analysis a few days back. The F6 dialyzer cost me around 1,700 rupees. So unless, and the remunerations are fixed for dialysis, the market as well as government agencies. So unless you reuse a dialyzer when you reuse a dialyzer, on the 17th occasion, cost of that dialyzer is 100 rupees. So the earlier we throw away the dialyzer, there is a flip side to it, that the cost of dialyzer as a component of the expense on the dialysis will be very high. 12th, I think it should be about 300 and 350 rupees. I don't remember the exact figure. But
the reason we kept it at 12 is that patients talking to each other, they started complaining, "Arey, uska 15 use hua. Why are you throwing my dialyzer?" So it becomes a little...
So what I'm thinking, propose to do is to take them to the dialysis unit.
Yes.
Yeah.
What I propose to do is to take them to the reuse area and show them the reuse and then show them the Excel sheet of KT by V per reuse. Because unless we do it, in the resource constraints that we have, it will be impossible to operate a dialysis unit.
So,
they have number of reuse?
No, I understand. His dialyzer is costing 17.
No. I'm talking about the cost of the dialyzer. I'm taking it the purchase, say, market price. I'm not taking the purchase price which corporates would have.
So you can continue with your question of whether to reuse or not to reuse.
Okay. Show me my slides.
Unfortunately, all the automated systems are supposed to give you a prompt when the fiber bundle volume has fallen below 80%, and it is not supposed to fill disinfectant in that situation. Unfortunately, this can be bypassed. And invariably, there is a nexus between the patient, some of the unit staff, and the engineer of that company. So he is told, please bypass that step. And so irrespective of what fiber bundle volume is there, the disinfectant is filled by the machine in that situation, and it is reused. So it is essential to have, what the machine also does is it gives you a little printout at the end of the process which tells you the fiber bundle volume and the pressure leak test result. So we insist that that has to be stuck on the patient's paper so that at least we can check at random from time to time, because otherwise if that step is bypassed, unfortunately just about everything in our technology, there is a mechanism by which you can bypass the safety. We will be showing you that in the course of this, what all can be bypassed.
Yeah. For reuse program, it is essential that the first time that you use the dialyzer, the fiber bundle volume should be checked. And you do not need to depend, you should not depend on the manufacturers. How many units actually do it? No. Before you, if you have a reuse program, the first use, you must first check the fiber bundle volume, but it is easier to take the dialyzer and start using it. Yeah. So how many units actually follow this?
Lot of variabilities.
No, you'll have to put parasitic acid in that and keep it before you. So it's not common practice to follow that dictum.
So there's another thing, you have a database. So you enter that this is the dialyzer I'm using, say F8, and its fiber bundle volume is 110. Now if you want to do it with each and every dialyzer, you'll have to change the database.
Yes. Every time, which is again practically, see, we are not talking just the books, we are talking practical. So it is extremely difficult to measure in a busy unit individual dialyzer for first fiber bundle volume. So you have to believe on the manufacturer's quote what they have given.
So what we did is we looked at this and we checked one entire batch. The variation is about 3 ml.
Okay.
For the F6, it's 78 and that's plus minus 3 ml.
Which is negligible. We can just disregard it, I guess.
Otherwise, if you do 27 dialysis a day and you've taken 27 new dialysis, I'm thinking 27 is a small number. There are some people who have bigger units than that.
Yeah.
So 27 times you'll have to change the database.
So, Dr. Ookalkar,
So
your take on
blood tubing.
blood tubings.
Yeah. So cost of the blood tubing is less than the cost of the dialyzer. So it doesn't make sense to reuse the blood tubing. Secondly, if you decide to reuse the blood tubing, at the moment I'm using only 1 liter saline because I'm using new blood tubings every time. Yes. So from 1 liter saline, it will go to 2 liter saline. The incremental cost will be 50 rupees. Yes. So how much will I save? 50 rupees. And plus I'll have the risk of having RIGORS on the unit. And what is the cost of my time to go and attend the RIGORS? Yes. So it is not worthwhile doing blood.
And sometimes with the reagent, the color of the tubing also changes.
Yeah, I have got a slide. Yes. Just show that slide.
And even the pump segment, it becomes harder. So your blood flow may not be absolutely correct.
Yeah. So this is the pink colored blood tubing. Somebody put the wrong dilution of parasitic acid. So all these things you'll see. So it's not worth the...
So all in all, I think unless there is compulsion from Arogyashri or Rajiv Gandhi
still
or all
50
those
rupees,
things.
sir. 50 rupees
No,
is
so
saving.
that's what I'm saying. Ultimately, the best way to manage is to avoid reuse of tubing and maybe reuse of dialyzer till today cannot be a norm. It has to be only in the people who can
even
afford.
in America, once upon a time, only 60% of dialysis units were having 20% of dialysis units were having single-use policy. 2 months back, once upon a time. 2 months back, I was in the US in the University Hospital, and there 90% of the is single-use. Now, what has changed? Because Fresenius is now operating the dialysis unit, and Fresenius is also manufacturing the dialyzers.
So we discussed some part of this, preparing the concentrates. So what all we need and what can go wrong here?
So basically the proportion of what you're using. So whether you can use in a small unit like 2 machines or 3 machines, then you can use in a jar and then you can transform it. So, and whether the glucose is there or not. So if the glucose, every concentrate may not have it, so best to add it so that at least more than 100 milligram, so that there will not be any hypoglycemia in these patients. But it is not, everybody is approved, some concentrates are not approved with glucose. So if there is any 2%, 4%, even a calcium, which I thought it is 1.5 calcium. It is not with glucose. It is not approved. So it's only higher, little bit of higher calcium is approved. So you can use in a small center. Otherwise, bigger. What we use, we have a big jar. We put 114 bags. We put it, and then it is machine driven. So it becomes completely. It becomes soluble, and then we'll take in the can and then use it for each machine. You can directly have a loop system also to every dialysis machine, and it can be go to the loop also. But only the problem is washing. It has to be used in one day. Previously, we used to get in Malaysia and other people, they used to use preparation. They used to use for 2 and 3 days, like a Baxter bag, PD bags. They used to collect it and then cut it, which is sterilized. They used to use it. But again, they have seen more infections at the end of 48 hours. So it has to be kept only for 1 day. The sir said the next day morning, if the same previous day bicarbonate solution is used, more of infection, especially when the bicarbonate is more. In the dialysis, they have seen more and more infection, especially when you have more than pre-dialysis bicarbonate is more than 26 and 27, more and more infections can happen. So it has to be cleaned. And the vessel which you use it for a big preparation, it has to be conical, it has to be drained completely, it has to be washed with an RO water every day, and every 7 days it has to be cleaned with an hypochlorite. And even the tubing, if there is a continuous system, it has to be flushed. Otherwise, you may have biofilms and then all this infection which can happen. We had similar, so Spinotropomonas was coming more frequently, and the bicarbonate preparation was at fault, so we need to clean. And now the Fresenius and other things, they have a buyback, or the other machines have a bicarb cartridge, which cost little bit more, but again it is more safer, and your endotoxins are much less. So both 750 and 1250, which are available, which can be used safely and which will reduce the cost.
Yeah, I think Sagar is going to discuss dialysate and the subsequent talks.
You all are using the
Buyback we started, but every machine, previous Nipro, it is not possible.
Yeah,
so
only
we have to
Fresenius.
use some, we have to use the preparation and then some buyback.
Right.
So we quickly go to machine maintenance.
Yeah.
So Dr. Khanna is going to explain.
Yeah, I think again we are going to have a detailed discussion later on, but you have chemical disinfection, heat disinfection, and cytothermal disinfection. Most of the new machines have their cleaning programs, and cytothermal disinfection is done at the end of the day. Between 2 dialysis sessions, if you are, for example, these days more of it was done between sessions, but otherwise at the end of the day, cytothermal disinfection. Between every session, the standard rinsing and surface cleaning is practiced. These cleaning programs actually are available in different menus. The hot rinse, so disinfection with hot disinfection with citrosteril at the end of the day is the commonly practiced method. Next. Yeah. So you were asking which are the solutions. The cold sterile, which is puristerile, peracetic based, the citrosteril, which is citric acid based, and the sodium hypochlorite, which is for the front, which you use it probably less frequently, once a month. But otherwise, hot disinfection, hot thermal disinfection, hot chemical disinfection is the main method which we have to use it. What gets disinfected? The balancing chamber, the flow pump, the degassing pump, the UF pump, the concentrate pumps, concentrate suction tubes, the heater block, and the DiaSafe Plus filters. So dialysis machine should be disinfected and decalcified at the end of the day with appropriate disinfectant to ensure that microorganisms, calcium deposits, and biomaterials are eradicated from the dialysate pathway. And of course, we forgot that in between, if there is a blood leak, then the disinfection should be there, not to wait till the end of the day, but after every blood leak.
So sir talked about front cleaning. So Dr. Ookalkar will elaborate.
So, continuing what Dr. Khanna was just now saying, this is the BC recommendations from Canada, and they recommend that at the end of every session, if it is an Hep B patient, you need to do an hydraulics disinfection, and at the end of the day for non-Hep B. This thing. But I spoke with the Fresenius engineer. He said if you start giving internal hydraulics disinfection at the end of every day, then your endotoxin filter will get fired very soon. So every time there is an internal disinfection, there is a clock which goes backwards from 12, and when it reaches 1 or 0, it will give an alarm that you need to change the endotoxin filter. So he said even if you do it once in 15 days, it's okay. And that's the recommendation that we are following as per the advice from the Fresenius engineer. If you do it every
chemical
day,
disinfection
no,
at the
not
end of-
hot. I'm talking about chemical disinfection
Chemical
at the end of the day. But if you do it every day, he says the endotoxin. I don't know what is your experience. This is
So we are doing every day hot.
what happens to your no. I'm
Hot,
not talking about hot. I am talking about chemical disinfection at the end of the day.
Yeah, I think hot citrosteril is disinfection. That's what we are talking of, right?
Yeah.
Yes.
Yeah.
I think what Dhananjay is talking about is the
Front cleaning.
Yeah.
Yes.
Yeah,
hypochlorite.
Yeah. That.
There are certain parts of the hydraulics which
correct.
Yeah.
Right.
are, and if that metal comes in frequent contact with hypochlorite, it's going to get
Right.
But citrosteril per se, at least once a day.
One side, right.
Correct.
So in
So-
between sessions, heat disinfection,
Yeah.
it takes 45, 50, 55 minutes.
Yes.
And then end of the day,
End of the day, hot chemical citrosteril
combination.
disinfection. And as he said, that the bleach to be
yeah.
used once in 15 days or a month,
Yeah.
depending on what.
Yeah.
And if you prolong, if you don't do it, citrosteril, I think sir said the biofilm, and then otherwise clogging, bicarbonate suction
Calcium.
may not be good. So
That's it.
we had earlier with Nipro machines, we had acidosis at the end of dialysis and hypotension, every problem.
So hot citrosteril is a must at the end of the day.
We can go to the managerial aspects. That what documents we are required to run a dialysis center, and what are the logs that we should maintain.
Yeah. Can I have the slide?
Yes.
So 36 laws apply to running a healthcare facility, and there are so many laws and so many that you require an administrator to take care of everything. From the time that you get into an infrastructure, the first thing is you must have an occupancy certificate, and none of the buildings in Nagpur have an occupancy certificate because no architect will approach the NMC to get an occupancy certificate. That means the NMC is taking up a responsibility that this building is safe, and Nagpur Municipal Corporation doesn't want to take that. So this is textbook like occupancy certificate, completion certificate. Fire NOC, yes. If you don't have a fire NOC, you don't get a license, so you will have to have that. Pollution Control Board has now started asking us to put an effluent treatment plant also in the unit, and the liquid waste that we create has to be disinfected before it is discharged in the common drain. And the clinical registration has to be done under the Clinical Establishment Act, if it or the municipal corporation. And you have registrations for doctors, nurses, clinical psychologists, and licenses. Next slide. So, number of these things. If you are going to own up a dialysis unit, then you have to take care of PF. And PF violation is a non-bailable thing. That is, if the PF people come behind you, you are straight behind bars. So you can't make a mistake on that. ESIC, minimum wages is also very sticky. If you violate that law, again, you'll have a lot of trouble with the labor board. And then there is the legal proofs, PAN card, shop and establishment registration, and GST, TDS, and long list of things. And these are the logs which need to be maintained. Again, this may not be complete, but these are logs related to machine, to the water, to the patient staff scheduling. Incident reports, I want to highlight. I don't have a slide. But in the United States, in the renal database, if you have undesirable or adverse event which occurs in the dialysis unit, that has to be entered into the log and has to be reported up. It may be as small as an extravasation of the fistula needle, to as much as a fall in the dialysis facility, to a mishap which occurs because of machine. So anything, some substance, anything which interferes with a safe stay of the patient in the dialysis unit has to be entered in logged.
So, what should be
So
the
whether the doctor is required for a dialysis facility in our
Yeah, he's
coming
coming
to
to
that.
that.
I'm coming.
So,
So-
what
so-
qualification of a dialysis technician
So I'm
should
giving
have?
you a textbook ISN guideline. So these are the so only saving grace when I was reading for this was I thought that unless you have a 1-year certificate holder as your dialysis technician, you will be in trouble. But no, there is a clause there which says, or with adequate experience. Or with adequate, that protects those people who do not have that degree.
I think the government also has put up, there are two such requirements. One is the ISN guidelines and there are government guidelines also. So that
what
two
did the
separate
government
ones.
do? It just picked up the
They
ISN
picked up the
guidelines
same.
and cut copy paste.
Accepted. The guidelines were sent to the Ministry of Health,
Yeah.
saying that this is what we have prepared, and they took it and put it on their website and said this is what you have.
Yeah.
So about dialysis doctors.
Okay, I think you must have a dialysis doctor unless you are the dialysis doctor. Meaning, if your volume of work is not so much, then you act as the dialysis doctor. But it is always safe that a patient is seen before a procedure which can cause mishap. So therefore, some kind of signature of a doctor is to be there before that the dialysis prescription can be modified legally only by a doctor. And that with training, if you have a dialysis doctor, a junior, then he can help you with quality assessment and process improvement, everything. And routine, repetitive medical paperwork can be done by that. And you have additional help if there is a cardiac arrest or an emergency. And he helps you in staff training. So if you can have that amount of work that you can afford a dialysis doctor, then you can have another person. Otherwise, you will have to do it yourself.
So these are the questions.
Yeah, I think just to add that the experience clause is actually useful, especially with so many dialysis centers mushrooming. You will not get all of them qualified technicians. So the experience clause helps. I think at least in Mumbai, we need fire, MPCB, and Gumasta license or shop and establishment. We don't even need for a daycare center a registration with the health authorities. For a daycare center, for a center where you admit the patient, you require a proper registration. And I agree with you, a dialysis doctor, let's be very honest, at least those who have full-time nephrologists in the center, it's fine, the nephrologist takes rounds. Those like in Mumbai where, you go to multiple centers, it's the dialysis doctor who is the heart of the dialysis unit. Based on how good the dialysis doctor is, the results of the patients over the long term for maintenance hemodialysis is required. So a dialysis doctor is worth...
BHMS versus BAMS.
Yeah. So I think the
BHMS versus BAMS.
These people made the guidelines. I'm not pointing fingers. I'm just saying you all have put the clause MBBS, right?
No, I wrote it.
MBBS.
Because BHMS doctors are not allowed to practice allopathy. And number of places...
So BAMS is now allowed. BAMS,
yeah.
not
BHMS is not there. BHMS is of no use.
And it's not possible, at least in my experience, to get MBBS doctors who are sitting in that small dialysis unit, seeing only dialysis patients and spending their whole life along with it. So they are busy. So you get them for 3 months till they are busy doing neat preparation.
So, but that is the law, sir. You cannot write anything in the guidelines which contravenes the law.
I think BAMS is permitted now,
Yeah, BAMS
according
may
to
be
me.
a face saver.
If somebody can correct me.
Yeah. So the last 3 questions.
Yeah, sorry.
These are
So the
coming
responsibilities, yes. At least the guidelines mention that a nephrologist should visit once a week at least. And I don't think that one nephrologist should, decide to lend his name to a center where he's not likely to go, because the vicarious responsibility of any unit rests with the nephrologist. The buck stops there.
Yes.
If there is a case, it will be both against the owner as well as the nephrologist. So I think one should lend your name only if you are going to go and supervise the unit. Once a week is the minimum requirement. You could, of course, decide to go depending on the requirement.
Okay. And if I find a irregularity in a unit which is owned by a hospital, let's not put into the corporate hospital, but a small hospital, nursing home, he's owning that unit. How do I proceed to tackle that irregularity?
So it depends upon many factors. What is the gravity of the irregularity? For example, if it's just record keeping or patient care, I think that can be sorted out within the department itself. If it is following of protocols, again, that can also be sorted out with a meeting with technicians and whoever doctors. So it may be multiple nephrologists visiting that center, or maybe dialysis doctor, as Dr. Khanna said. So we can sit across, discuss things and sort it out. But if there are irregularities in terms of, for example, supplies, manpower, then obviously management has to be brought into it, because dialysis doctor or dialysis unit are not going to look after it. And major flaws of patient care management. For example, somebody said that tap water is being used or these kind of management, which we nephrologists will never agree to it, then that either we have to bring to the attention to the management that this is not acceptable, or lastly you have to take your name off from that center. Otherwise, the onus lies on nephrologists. You have to understand, if anything happens to the dialysis unit, and my name, I have given my name to that dialysis. I'm not talking about again full-timers because we are obviously. So even the small centers or mushrooming centers where I have lent my name, whether I'm visiting once in a week or not, if my name is there and I've signed a contract, then I'm responsible for the unit. Anything happens and a complaint or lawsuit is filed, I'll have to answer that question. So we have to safeguard not only patients' right, we have to safeguard ourselves as well. And in that context, it's better to resign rather than, you can always fight with the management and get things done. If it is not doable, then I don't think there is any other way but to get our names out of that unit. Because the irregularities can be of different grade. So it can be a big lecture in itself.
Yes.
I think panelists can also comment on this.
So there was one big chain, dialysis chain, which took over a medical college dialysis facility, and the nephrologist was sharing it with me that every second patient was having a RIGOR because they were reusing the blood tubing. They were servicing the Mahatma Jyotiba Phule market. And he told the management that either you see that they use single use or I'm stopping coming from 1 month from now.
And that has to be documented, I think. Either
It has to be
written
written
letter
or
a mail.
Yeah.
Does audience have any question to the panelist? Yeah, it's already. Yeah, Vipul.
As we know that the dialysis patients, the cardiovascular morbidity is really high in those patients. So when we enroll any new patients in our maintenance list, should we be taking any death on the dialysis consent or?
Death on the dialysis consent is not 007, James Bond, license to kill. So the lawyer is going to give anyway a tough death on the dialysis possibility. Anyway, a negligence can be always filed.
The ideal consent form, it includes all the possible complications, including death. And ideally, what I prepared in Aditya Birla way back is percentage-wise. So you can get 20% can get hypotension. It's always clearly mentioned that these many patients can get these kind of complications, and they do sign the consent. And earlier we used to take once in a month, but now it is mandatory. Every time they come to dialysis unit, they have to sign that consent form.
And the consent.
Answer is correct. You have to take a consent. What he says also is correct. That if there is death, you don't get absolved from the negligence part by taking a consent. But if you don't have a consent, then you are in deeper trouble. That's all. No,
take at least 3 months.
No, now we have started taking every dialysis. There is a consent form. As soon as they come on bed, they sign that consent.
Is this somewhere, what frequency should be taken? Is it anywhere laid down?
not that
Lay
I
down, but when you discuss medical legal affairs, when we have a meeting, they say every procedure has to be documented every time.
So I think
So
it's
it's not in the
individual hospital.
guidelines. So we should look into that. Into the guideline, whether we should take it every time, monthly or 3 months. Earlier we used to take monthly. But now medical, whenever we had a problem or no problem, but when we sit across the lawyer, they say medical consultant that you have to have every time.
Because if you did an operation and then you were reoperating for a complication,
You need a consent.
you would have to take it.
So they are going by the letter of the, rather than the spirit of the law. They are going
I
by the
think
letter.
best is to take it.
Yeah, safer. Na?
And the consent has to be in the language the patient understands. If it is in English, it is of no use.